So I'll be talking to you this morning about gastric or stomach cancer. I have put my email up here. I'd certainly welcome questions if they arise, and we can certainly talk about some at the end of the talk. So I am an assistant professor of medicine in the Division of Oncology at Stanford, and I received my medical degree at Dartmouth, which is in New Hampshire on the eastern coast of the United States, but did all of my other medical training at Stanford, a residency in internal medicine and fellowship in oncology, and I have stayed on faculty and focus exclusively on GI cancers, where I spend about half my time in patient care and the other half running and designing clinical trials in GI cancers. These are my disclosures. They're mostly around the clinical trials that I do. I thought I would, this was educational for me, I thought I would start with a little bit of context of cancer burden in sub-Saharan Africa, which will frame a little bit of how we think about treating and diagnosing cancers in your area. So cancer burden is actually mounting quite a bit and rivaling that of many of the more common infections that are seen in sub-Saharan Africa, and deaths remain high due to late diagnosis and lack of treatment. In 2012, there were an estimated over 600,000 new cases of cancer and 450,000 cancer deaths in the region. Deaths from cancer are expected to actually double by 2030 due to the aging population. I think that's actually true worldwide as our population ages and cancer becomes more of a health burden. And global funding for cancer prevention and treatment in lower income countries is far lower than diseases, as I'd mentioned, some of the infectious diseases such as HIV, malaria, tuberculosis. There were, actually just even in the last 6 months, there has been a fair amount of attention drawn to cancer as a health burden in Africa. I came across a New York Times article, which is the one up top, and actually the American Cancer Society, in combination with a few pharmaceutical industries, have really made it a priority to try to bring some of the most commonly used chemotherapies to some of the developing countries in Africa. And I'll get to that a little bit later, but I think that helped me think about how to talk about treatment of stomach cancer. So the other thing I'd like to introduce you to is something that we use a lot in the United States called the NCCN Guidelines, but there are guidelines that are really accessed throughout the world. NCCN stands for the National Comprehensive Cancer Network, and it's a nonprofit alliance of about 27 cancer centers in the United States. It's dedicated to improving quality, effectiveness, and efficiency of cancer care so that patients can live better. And it's really a very comprehensive set of guidelines. It's designed like an algorithm. We'll take a look at it. And that's a really quick reference for how to both diagnose and treat patients with cancer. And just as of December of 2017, so really in the last 6 months, there's been a brand new effort to try to develop guidelines that are applicable to sub-Saharan Africa. This was a big effort between the American Cancer Society, the African Cancer Coalition, Clinton Health Access Initiative, and some pharmaceutical companies. And these guidelines represent optimal care that countries in sub-Saharan Africa aspire to provide, and really more pragmatic. So what types of chemotherapies and treatment are accessible to you, and how does that fit into the guidelines? So right now, it does not include gastric cancer. They are working on others. You can see here, this is the list of guidelines that exist currently for the sub-Saharan African population. They include adult cancer pain, breast cancer, cervical cancer, chronic lymphocytic leukemia, Kaposi sarcoma, non-Hodgkin's lymphoma, palliative care, and prostate cancer. So as you can see, some of them are around supportive care guidelines, around pain management, and also specifically around cancers. So in these harmonized guidelines, there are color coding to help determine what is generally available as standard of care, that's black, in gray, guidelines that may be highly advanced, that may be costly, technically challenging, or have lesser impact, and then blue, regional options that may be considered when available. So just as an example, this is part of the breast cancer guidelines for looking at ductal carcinoma in situ, sort of a precancer, and you can see that things such as in the workup along the left column, history and physical exam, mammogram, pathology review, those are things that are going to be standard. And then in gray, maybe advanced but impractical, and in blue, maybe regional. So we're going to move on to actually talking about gastric cancer. The first module is on pathophysiology. I'd like to frame this with just a clinical vignette. We'll maybe go back to this a few times during the presentation. So this is a 66-year-old man who has a 6-month history of dyspepsia without dysphagia or weight loss. Although his symptoms previously responded to antacids, over-the-counter H2 receptor antagonists, these medications have been ineffective for the last 2 months. His physical exam and complete blood count are normal. So which of the following is the most appropriate next step in the management of this patient? Either testing for H. pylori, a CT scan of the abdomen, upper endoscopy, radionuclide gastric emptying study, that's a nuclear medicine test, or doing an 8-week trial of a proton pump inhibitor. And I'll let you think about that. So the answer for this one is an upper endoscopy, and we'll talk about why that is. My understanding is that though you may not have that immediately available right where you are, but that perhaps that can be referred to, but we can certainly talk about that at the end. So in terms of gastric cancer epidemiology, gastric cancer is actually the 4th leading cause of new cancer cases worldwide. So it is a really important high health burden cancer across the world, although in the United States, it's actually much less common. And worldwide, it's the 2nd leading cause of cancer-related deaths. Gastric cancer is probably the most common in some of the Asian and East Asian countries, as opposed to more Western countries, and that we'll talk about why that is. This is just a map showing the global incidence of cancer. The legend shows incidence per 100,000 cases. The dark green are areas that are really high incidence regions. So you can see that in Eastern Europe and the large majority of Asian countries have very high incidence. If we were to look at Africa, it is a little bit mixed, but the very light green actually shows that there's no data. And we'll talk a little bit about why that is and why perhaps gastric cancer may be more common than is appreciated. This is a graph to show global patterns of gastric cancer incidence by country. On the left are males and on the right is females, and it's color-coded with the legend along the bottom. African countries are in sort of a purpley pink color. The most common of 9 per 100,000, you can see here, is Zimbabwe. And that's for males. And then for females in Uganda at about 7 per 100,000 cases diagnosed per year. All right, let's talk a little bit about how we classify stomach cancer. So in the picture on the left, you can see a picture of the stomach and the esophagus. Esophageal and GE junction cancers are right next to the stomach. They are classified by something called the Siewert classification of type 1, type 2, and type 3. Type 1 is really here just at the lower portion of the esophagus. Type 2 includes the GE junction. And type 3 includes anything from just below the GE junction to the top part of the stomach. Stomach cancer formally then just includes the body and the antrum. Epidemiology patterns are really shifting more in developed countries, including the United States. It's much more common to see tumors in this GE junction area than in the more distal part of the stomach. And adenocarcinoma is quite a bit more common nowadays than squamous cell carcinoma. Squamous we would generally only see in the esophagus. Adenocarcinoma is in the GE junction and further down into the stomach. Let's talk a little bit about risk factors. So there are both risk factors that are modifiable and ones that are not. So in terms of nutritional risk factors, low fat or protein consumption can increase risk, as can salted meat or fish, and high nitrate consumption. Medical risk factors include prior gastric surgery, H. pylori infection, which increases the risk for gastric cancer twofold, and gastric atrophy or gastritis. Environmental risk factors include poor food preparation, such as smoked foods. That's actually quite common in some of the Asian countries. Lack of refrigeration, poor drinking water or well water, occupation, such as workers in rubber, coal, and metal, and smoking increased risks by 1.6 times, and then low socioeconomic class, which probably speaks more to access to care. This is a map of H. pylori infection, and I thought this was, I don't have these exactly overlaid in terms of the incidence of gastric cancer, but if you recall that other map, those do overlay quite nicely. So the purple and blue color show reported prevalence of H. pylori infection that is quite high. So in Eastern Europe, China, Japan, India, some of the countries in Africa are listed here, Libya, Egypt, and these are, because this is an infectious risk factor, it's potentially modifiable. Much of Africa is just unknown. I think that the rates of H. pylori infection are not well described. Because this is perhaps relevant to you and your patient population, H. pylori infection is felt to be quite common and very prevalent infection in much of Africa. The indications for testing include patients who have a duodenal ulcer, gastric ulcer, atrophic gastritis, gastric malt lymphoma, following resection of an early gastric cancer, or uninvestigated dyspepsia in areas with a high prevalence, which would very likely be your patient population. Testing options include, there are a variety, blood test, breath test, stool test, and biopsy by esophagogastroduodenoscopy, so EGD. And then treatment is actually quite simple. It is a 3-drug treatment of clarithromycin, amoxicillin, and a proton and pump inhibitor for about 14 days, though I have seen some studies look at 7 days. Okay, so that's the first section on the pathophysiology of gastric cancer. So MSI high cancers are especially susceptible to immunotherapy. Lynch syndrome is the classic example of MSI high cancers. And then about 20% of stomach cancers are genomically stable, and the other 50% fall into this category of chromosomal instability. An Asian research group also did a very similar molecular classification, found similar results. But the take home from this slide is that we are learning more how to put these cancers into buckets based on molecular subtypes, and that's true for all cancers. In terms of prognosis, unfortunately, stomach cancer is one of our most aggressive cancers. Only about 25% are localized at the time of diagnosis. About 30% have lymph node involvement at diagnosis, and about 30% have metastatic disease at diagnosis. 5-year survival for all comers is only about 25%. That generally speaks to the fact that most of these cancers are already spread at the time they're diagnosed. For metastatic disease, the median survival is under a year. So I'd like you to sort of think about stomach cancer and break it really into 2 categories. So one is localized, meaning could a surgeon remove the cancer? If that's the case, we use multimodality treatment, including surgery, chemotherapy, and radiation. The other branch point is this cancer unresectable or metastatic, in which case only chemotherapy will be used for treatment. So let's talk a little bit about chemotherapy or treatment for localized disease. There are actually a few options. I've presented two main options here. So one is considering surgery first, followed by chemotherapy and radiation. I've given an example of a chemotherapy that's used commonly here, which is one that is available in sub-Saharan Africa, 5-FU. And then chemotherapy followed by surgery, followed by more chemotherapy is another acceptable approach. In fact, that's probably more commonly used. The pendulum is probably swinging towards that. I've listed some chemotherapies here, which also, many of which are available to you. Treatment for metastatic disease, as I'd mentioned, is chemotherapy only. Once a cancer has spread from where it started, whether it goes to the lungs or the liver, it is no longer curable. I should mention in the context of this that as I'm talking with patients, I try to be very clear when I first meet them, talking about what the goals of treatment are. So if they have a localized cancer, we talk and say, well, the goals of treatment are curative, versus if their cancer has already spread, we'll talk about how the goals of therapy are palliative, really hoping to give them as much time, but have that be good quality time. So in terms of access to chemotherapy, as I'd mentioned in some of those earlier slides around that New York Times article and some of the efforts with the American Cancer Society, two companies came forward in late 2017 to try to provide lower cost chemotherapies to many African countries. These specific chemotherapies are listed here. You do not need to memorize these, but in bold, I have put some of the chemotherapies that are used commonly for stomach cancer. So I suspect that many of these may be available, though not widely. So let's talk just briefly about some of the side effects of chemotherapy. So chemotherapy gets a bad rap. Not all chemotherapy is all that hard. And I think with appropriate supportive measures such as anti-nausea medicines, that can be easier. So fluoropyrimidines include things like 5-FU. Capecitabine is an oral form of that. 5-FU is infusional. These can cause nausea, diarrhea, something called hand-foot skin syndrome, which is a dryness and cracking of the palms and soles. The platinum class of chemotherapies can cause nausea, neuropathy, such as hearing loss or numbness and tingling in the fingers and toes. Cisplatin can cause nephrotoxicity and myelosuppression, which includes lowering of blood counts. And then oxaliplatin, which is another platinum, can cause some of those same side effects. And then taxanes, another class, which includes one called paclitaxel, can also cause nausea, neuropathy, and lowering of blood counts. We talked about radiation in the context of gastric cancer. It's not an absolute requirement. Chemotherapy alone before and after surgery is acceptable. Post-operatively, radiation is still sometimes used. Based on sort of my digging around a little bit, it seems that access to radiation is probably fairly limited in much of Africa, and so that it may or may not be available to you. I would say that also in terms of treating patients with metastatic disease, we will sometimes use radiation to help treat painful bone sites. Sometimes using radiation to the esophagus can help open that up and help patients swallow a little bit better. Side effects of radiation include skin toxicity. So think of it like a bad sunburn. The skin can become blistered and red and peel. On the inside, so if we're radiating the GI tract, the stomach and the esophagus, can cause something called mucositis. So that's like a sunburn on the inside, nausea, vomiting, and one of the most common side effects is fatigue. So let's say that we get our patient all the way through a surgery and chemotherapy that was for curative intent. We would then move into a phase called surveillance, where we want to monitor the patient. Generally, we would, and this is per the NCCN guidelines, we would do an H&P every 3 to 6 months for 1 to 2 years, then every 6 to 12 months for 3 to 5 years, and annually thereafter. The CBC and chemistry blood tests are done as clinically indicated. And EGD, that esophagogastroduodenoscopy, upper endoscopy, is also only done as clinically needed. And CT scans are done every 6 to 12 months for the first 2 years, and then annually for up to 5 years. And then we also recommend monitoring for nutritional deficiencies because of after a gastrectomy, patients are at higher risk for B12 and iron deficiencies. I'd like to touch briefly on the principles of survivorship. So this is a relatively new field in cancer where the definition of cancer survivorship is thinking about how to take the best care of the patient before, during, and after their diagnosis, really focusing on patient well-being. So we talk about managing long-term sequelae of disease or treatment. General issues include things like weight loss, diarrhea, chemotherapy, chemotherapy-related neuropathy, fatigue, and bone health. Specific issues for gastrectomy survivors include indigestion, B12 deficiency, distal gastrectomy, and iron deficiency. And we also counsel patients regarding health behaviors, include routine cancer screening, and then survivorship care planning and coordination of care. This also helps really bring in patients' primary care physicians, engages them in some of this monitoring and follow-up. So primary prevention for stomach cancer, so meaning how can we prevent stomach cancer before it even starts? As we talked about some of the risk factors previously, there are modifiable risk factors. Dietary risk factors include, or preventing those include avoiding a diet that's high in smoked and pickled foods, salted meats and fish, do a diet high in fresh fruits and vegetables. Being overweight or obese can add to the risk of stomach cancer, so physical activity may help lower your risk. Avoiding tobacco use, and then treating H. pylori infections as we discussed earlier. Module 5 includes some future directions. I alluded to this a little bit already, but I really think that the future of cancer care includes testing for somatic mutations that can guide therapy. So let's just talk briefly on, well, what types of mutations matter in cancer. And really, I tell patients and providers that there are 2 types. So there are the mutations in the tumor. Those are the somatic mutations. And then there are the mutations in your germline. So those are the mutations or the DNA that's passed from parent to child. So here we're talking about mutations in the tumor. So now pretty routinely in the US and hopefully later in developing countries, we are routinely doing a molecular profile on the tumor DNA to try to help identify some of these genes that may either be targets for drugs, may help determine that certain drugs may not be effective. It's really helping to tailor or personalize the treatment to those patients. So 2 examples listed here include one is HER2 positivity that is present in about 20% of patients with stomach cancer. The target for that is trastuzumab, that's Herceptin. A little tip on this alphabet soup of chemo names, anything that ends in an AB stands for an antibody. And then PD-L1 positive, this is a brand new immune marker that's present in about 15% of gastric cancers. Pembrolizumab, which is a special immune modifying treatment, helps target that and was just recently approved for gastric cancer. Let's move on. We have the last kind of few modules. Module 6 is what a healthcare worker should know. So this is a little bit of review, but I think it's really important to sort of for you all, but also educating community healthcare workers on symptoms of gastric cancer. So what types of symptoms might they be reporting? That include dysphagia, fatigue, unintentional weight loss, abdominal pain, nausea and vomiting. And then signs of gastric cancer, particularly on blood work, might include anemia or vomiting of blood, vomiting something called coffee grounds. So when blood is digested in the stomach, it can look just like coffee grounds. So it looks sort of dark and particulate. And then melena or black stools. Also important to spread the word that gastric cancer can be caused by a bacteria called H. pylori, which is very common in much of Africa, but very treatable. And then when patients are diagnosed early, gastric cancer is curable, but if diagnosed late, which is unfortunately more common, treatment is palliative. Also sort of messaging how to take care of patients after they've had treatment. So for patients who've had a gastrectomy, they may get full easily, therefore more frequent and smaller meals are probably easier to tolerate. We recommend monitoring for B12 deficiency and iron deficiency in these patients. And then if patients after a gastrectomy were to have trouble swallowing, dysphagia can sometimes result from strictures due to scar tissue, so that's important to just keep in mind. For patients receiving chemotherapy and radiation, recall that chemotherapy may cause fatigue, nausea, and increased risk of infections, and we really encourage hydration and more frequent and smaller meals for patients who are receiving chemotherapy or radiation. So what should a patient know? Module 7. I think that we want to empower patients to really contact their healthcare providers with persistent symptoms that include weight loss, abdominal pain, vomiting of blood, vomiting of that coffee ground materia, or black stools. Gastric cancer treatment options include surgery, chemotherapy, and radiation. And then we also want patients to really understand what is their stage and what are the goals of treatment. So just a couple of slides on take-home points, and then I'm happy to answer some questions. So recall that incidence rates really vary by geographic region. Very common, gastric cancer is very common worldwide. It's less common in developed countries. Modifiable risk factors include H. pylori infection and diet. Esophagogastric cancers are proving to be many separate diseases, not a single disease. So as we talked, there are G junction and gastric, intestinal and diffuse type, and now we know that there are some molecular subtypes that may impact treatment. And then molecularly targeted therapies are really the future of how we're going to help tailor therapies to patients. No questions? Have any of you guys taken care of patients with stomach cancer or seen patients with stomach cancer?
So we have a lot of HIV around here. So I don't want to talk about the HIV population. Let's talk about immune competent patients. Now we have them coming with symptoms of dyspepsia. We really do not want to do upper endoscopy for everybody who comes in with symptoms of dyspepsia. So is there a cutoff age where you would consider doing endoscopy in immunocompetent patients, and maybe when you will not? And then my second question is, when we do upper endoscopy, we see gastric ulcers. Sometimes we see duodenal ulcers. Our practice here for some time now has been to treat the patient with duodenal ulcers, to get them on H. pylori eradication, and then maybe to repeat the upper endoscopy maybe 3 weeks or 4 weeks. And then for those patients with gastric ulcers, we usually do a biopsy. So my question is, how large should a gastric ulcer be for you to consider biopsy, or do you biopsy all gastric ulcers?
Okay, so good, really good questions. I'll try to tackle some of these. I would say that for your HIV immunocompromised population, in terms of dyspepsia and thinking about endoscopy, I agree with you that that population, especially if they're young, may not be at particularly high risk for gastric cancer. Gastric cancer median age is generally 60 and above. I think it's sort of weighing risks, benefits, and what other comorbidities they may have. So I understand that you would worry that in that population, an endoscopy might place them at higher risk for infection. So perhaps it's waiting a longer period of time, or if they're older and those symptoms persist, then perhaps considering an endoscopy. In terms of your second question, I completely agree. That approach sounds very reasonable for your population. If you identify a gastric or duodenal ulcer, trying to eradicate the H. pylori first, maybe then repeating endoscopy, and if the ulcer persists, then it probably makes sense to try to biopsy, just because we know that those ulcers can predispose to formation of cancer. You asked about size. I am not a gastroenterologist, so I don't know that size necessarily determines whether or not it's going to be cancer or not, but I would say that we have a pretty low threshold for biopsying ulcers.
Okay, thank you.